Welcome back, guys. So, in this video, in this module, what we're going to see is we're going to see about the process of acute inflammation. Last module, we saw both the cells of acute inflammation, cells of chronic inflammation, and different types of inflammatory cells, how to identify them in microscope. Here, we are going to go into, I'm going to see stepwise how actually an acute inflammation happens. We'll take an example of an infection, and we are going to see that how my immune system is going to eliminate the infection from our body. That's the entire purpose of this module. Fine. So what you're going to see is the steps of acute inflammation. Right? Let's start. Put a smile on your face and let's start listening. Okay. So for the ease of understanding, we are going to divide the steps of acute inflammation into two different things. We're going to call them as cellular phase of acute inflammation, and we are also going to call them as vascular phase of acute inflammation. We have something called as cellular phase, what happens in respect to the cells, which are the WBCs, and what happens with respect to the vessels during acute inflammation, just for ease of understanding. I am clarifying now itself, inside the body, this cellular phase and vascular phase occurs simultaneously. Just for understanding, we are just dividing them into two things, right? Cellular as well as vascular phase. So our entire motive for this module is, let's assume this is a vessel. Let's assume that this guy is the infection, streptococcus, right? So my entire motto of this lecture is the WBC inside the vessel, how they are going to come outside and how they are going to go to the streptococci and how they are going to destroy them. That's the entire motto of this video, right? Step by step, how they are going to go, that's what we are going to see. So when we know normal, if any steps goes abnormal, we are going to see look at the diseases as well, right? Shall we? Yeah, we shall. So first in this, we are going to see about the vascular phase. Then obviously we'll go to the cellular phase, right? So we'll see what will happen to the vessels during an acute inflammation, right? So we're going to see about the vascular phase first, then we'll go to the cellular phase. So in vascular phase of acute inflammation, let's assume like this. So there was an infection, my cells should go outside. And you already know that the hallmark of acute inflammation is increase in vascular permeability. That's what is going to happen here. But immediately after an infection, it's an instinct, right? If someone comes and hits you, what will your first thing? You will protect yourself, right? You will protect yourself. So obviously that will be there inside my vessel also. So when first an infectious organism comes, I'm going to vasoconstrict. I'm going to try to protect myself. Then I'm going to see streptococcus, vasodilate, send my WBCs outside and kill them. Same thing happens here. The first and the foremost thing is going to be, there will be an initial vasoconstriction. There will be an initial vasoconstriction which will happen. Initially there will be a vasoconstriction, but it will be transient. It will be transient for sure. This is just a spinal response. Initial vasoconstriction and it's going to be transient. After that, what happens is the vessel, let's assume this is a normal vessel, you'll have a vasodilatation. The vessel will become bigger. Maybe not this big, but yes, there will be vasodilatation. There will be a vasodilatation. This vasodilatation is going to be most commonly seen, or almost every change, whatever we are going to see in inflammation, is most commonly seen in post-capillary venules. Fine. It's most commonly seen in post-capillary venules. Not only this vasoconstriction, your increase in vascular permeability, everything is commonly seen in post-capillary venules, except in one organ, which is lungs. In lungs, it happens in capillaries. I'll also tell why. Generally, why post-capillary venules? Thin walled, easy to break and easy to go outside. Why in lungs capillaries? Lungs, the site of infection is going to be alveoli. And alveoli is entirely surrounded by capillaries, not by venules. That's why the seat of infection is in the alveoli, and I have lots of capillaries there. I'm not having any venules there. So in lungs, it's going to happen in capillaries. Clear? Fine. Now, when this vasodilatation happens, I'm going to have a slight little bit of change in the blood flow. See, look at the normal. In a normal vessel, I'm just going to draw the same thing below. In a normal vessel, what will happen is, you will have a blood flow called as laminar blood flow, right? Center there will be cells, surrounding that there will be plasma. In center I'll have cells and surrounding that I'll have plasma. In a normal vessel I'm going to have an laminar blood flow. But when the vessel becomes dilated, when there's a vasodilatation, obviously it's going to become turbulent, right? If you've been to a river rafting, whenever the river bifurcates, divides, there'll be a turbulence, right? Same thing happens here. My blood was initially going normal, smooth, no problem at all. When it comes here, it's going to become turbulent. When it comes here, it's going to become turbulent, right? It's going to become turbulent. Simple thing like when you put salt in or sugar in a tumbler and you mix it, that's turbulence. When turbulence happens, what will happen to the bottom? The sugar will go to the bottom, right? The heavy particles will go to the bottom. Here, what is the heavy particle? The cells. When turbulence happens, the cells goes to the corner. That's natural. That's nature, right? It's natural phenomenon. My cells goes to the corner. That's what happens. This process, I'm going to term them as margination. This process is called as an margination. I want to tell two things here. Who caused this margination? Vascular change, vasodilatation. It's primarily a vascular phenomenon. But there's also one thing, selectin. Selectin helps in margination. So I'm telling because there's an MCQ based on that, that's why you have to know, right? The primarily is a vascular phenomenon. It's because of vessels only. Okay, it's a vascular phenomenon. But selectin also helps. Fine, selectin also helps. That's my first change, vasodilatation. We are not come to the next second one, increase in vascular permeability. See, dilated vessel alone is not enough. I need my endothelium to give me way. Only then I can go outside, right? Like for example, I'm inside a room. The door is closed. I cannot go outside. Only when the door opens and I also have to move and go outside. The door opening here is the vascular phase. Me getting up and walking outside is the cellular phase. Clear? That's about the two phases of inflammation. So what you're going to see is how an increased vascular permeability happens. How there is an increased vascular permeability. Okay, how it happens. I want to say a few things here. See, over the period of years, when there was 7th edition, 8th edition, 9th edition, and 10th edition of Robbins, this increase in vascular permeability kind of constricted a lot. I'm not going with the latest, I'm going with a bit earlier edition of Robbins for the only reason it was much more detailed there because that amount of detailedness is required for us to extrapolate in future when we talk about inflammatory diseases, right? So we're going to be a little bit detailed, right? The first one, I'm going to call it an immediate and transient response. Right? It's an immediate and transient response. For all of these responses, I'm going to give you a practical scenario which all of you can link with. The immediate and transient response is like a coffee spill, hot coffee spill. You get a coffee from your mom or dad. When you buy, suddenly it tumbles and you have a spill. When the coffee spills, what you do is you wash the coffee. Within 15-20 minutes, the soreness will go away, right? It won't be there for the entire day or 2 or 3 days together. It will go away. Or a friend of yours pinches. I'll have it pain for like 15 minutes max. All those are immediate and transient response. So whenever I have a very less stimulus, I'm not talking about a boiling water, just a hot coffee, right? Imagine your hostel coffee. You will have no response only, right? An immediate and transient response. Whenever I have a mild stimulus, I'm just dividing it based on the stimulus. Could be a slight pinch, a tap, or a coffee spill. Whenever it happens, this mild stimulus will increase histamine secretion. We know about histamine, right? When it increases histamine, this is going to cause endothelial contraction. Fine, it's going to cause endothelial contraction. Fine. So what will happen is, the histamine, if this is my endothelium, I'm just drawing endothelium, the vessel, okay? I'm just drawing with one color, but as all you know, nucleus will always be blue. Fine. I have endothelium. When it contracts, what's going to happen is, my endothelium is going to become like this. I'm going to have space. Just for understanding, the other side I'm drawing it completely. One side alone I have contracted the endothelium. So what happens is, I have a space now for my plasma or for my cells to go outside. That's the ultimate goal. In other words, my door is just contracting and opening and giving me space for me to move out. Clear? Why this is short-lived? Because it's histamine. Histamine will have a T-half, right? The half-life of histamine is going to be around 15 to 30 minutes. And obviously, the response will last only for that time, right? Only for that time, the response is going to last. I'm not going to pinpoint on 15 minutes. Around that 15 minutes, it will last. After that, it will automatically go off. Because after that, no histamine, endothelium comes back to normal, no vascular permeability, no inflammation. Fine? That's all. That's first one. Second one. Immediate and sustained response. Right? This is going to be immediate and sustained response. So immediate and sustained response also, I'm going to give you a clinical, normal real life scenario so that you can easily link it with. I'm sure if at least some of you will cook, right? Not Maggi noodles, something better than that. Cooking related burns or cooking related boil. If you don't know, if you have not had a boil, ask your mom. Your mom will tell you exactly what's going to happen. Sometimes when you touch a hot vessel, while cooking, by mistake, accident, you touch it. What will happen is you'll have immediately a tiny little bit of swelling. Give it few minutes, you'll have a tiny little bump. The bump is nothing but increased vascular permeability. Right? Just the fluid, there's a plasma coming outside. It's immediate. Why I'm saying sustained is that bump will keep on increasing in size for the next few hours. If you've noticed, that'll definitely happen. It will keep on increasing in size for next few hours. After that, it will stop. It will not become big for next 2-3 days. It will not keep on becoming big. After a few hours, it will stop. Sustain, not transient, sustain. The bump will take 2 days or so to return back because the fluid has to go via the lymphatics to come back to my circulation. That will take time. But the bump will not increase in size after a few hours. That's why immediate and sustained. Few hours. Your mom would have told you, if you got a bump, your mom would have told you, the boil, don't prick the boil. Your mom would have told you, don't prick the boil. What you will do first? Prick the boil. Introduce infection, make an acute inflammation, chronic inflammation, end up with a scar formation. Your mom also would have told the same thing. Don't prick, you will have a scar. Your mom knows more medicine than you can ever know because she has lived for 50 years. That's the only difference. Experience is the most important thing. And while having experience, you have to relate medicine to every day-to-day life. Then you can become amazing. Your mom knows so much without reading textbooks. Unfortunately, we don't know after reading textbooks because we're not applying it. We're just reading it. I don't want that. My motive for you guys is not your first rank. My motive for you guys is understanding. That's my only motive. You understand, I'll be happy. You get first rank, that's a part and parcel of life. I'm not going to be bothered about that at all, right? Understanding, most important. So now we'll go to immediate and sustained response. When I have a moderate thermal injury, it's related to thermal only. When you have a moderate thermal injury, what's going to happen? There will be a direct endothelial damage here. There will be an endothelial damage, but it will be reversible, right? There will be an reversible endothelial damage. Okay? Endothelial injury or endothelial damage. This reversible endothelial damage is going to be there. The damage is going to be there for few hours. It will be there for few hours. So the inflammation is going to last for few hours. Okay? Maximum 12 hours. Maximum 12 hours, not beyond that. Right? So you'll have a blood vessel. The same thing I'm drawing. Normal blood vessel. So what's going to happen here is you're going to have a damage. I'm just drawing irregular endothelium to say it is damaged reversibly. During damage, it will come out. But my body's mechanism is very fast. It will seal the damage within few hours. Right? So the inflammation can last. It will start immediately. It can last for maximum 12 hours. Right? Maximum few hours to maximum 12 hours. After that, when this inflammation happens, there will be an increased permeability of the blood vessel. During the increased permeability is where you will have the boil. The boil is nothing but the plasma accumulation outside the vessel, right? You'll have a boil. The boil will return back to normal within 2 weeks, say 2 days, because of the lymphatic flow will take the fluid back to my body, right? It will return back to normal. Normalcy will happen in a day or two because the fluid returns via lymphatics into my body. So it's nothing to worry. Unless and until we complicate it, nothing to worry because you know the knowledge of inflammation. There is no infection at all here. It's a thermal injury. Only when infection comes, I'm going to be bothered, right? Okay, that's about it. So we have seen about two things. Third is going to be delayed and prolonged response, right? Third, we are going to call it as delayed and prolonged response. And it's going to be delayed and prolonged response. What does it mean? I'm sure few of you must have been to Goa, right? If you're living in Goa, amazing. Gifted guys. Most of you have been to Goa. For what? Obviously we know, right? Kingfisher and sunbathing. Not to take sunbathing. Indians will never take sunbathing. Even if you give them 1,000 rupees, they'll say, I'll stay inside home. And stupid foreigners, no. They take sunbathing and we go and watch it. See, they are foreigners. They have to be safety, right? That's the only reason we go and watch it. Nothing else. So when you take a sunbathing, when you get injured by radiation, that's what I'm concerned about. Delayed and prolonged response is seen in radiation-induced damage. That's my only concern here. When I have radiation, I gave an example of UV rays so that you can relate to it. They take sun bath because they want to tan. We apply Fair and Lovely because we want to be fair, right? Irony, right? Same irony will happen for you guys also. I'll tell you when. When you join first year PG, till that time you want to crack PG exam. When you join the first year PG, you'll say, I'll go to entrance preparation because that will royally screw you up. Fine. So now let's come back to the topic. When I have a radiation induced damage, what's going to happen here is, it's not a direct damage. I have UV rays. The UV rays will cause mutation. The mutation will be repaired. The mutation will cause, I'm just left one point, mutation will cause endothelial damage. The endothelial damage is a time where I have the increased permeability. I have increased permeability during that time. It's just a mutation, right? Any mutation in my body is automatically going to repair. Then I'll have the repair of the mutation. When I have repair of the mutation, it comes back to normalcy again. It will come back to normalcy again. See, this is the flowchart. This is how it happens when anyone is going to stay in sun for a longer time. Look back at the heading. I said delayed and a prolonged response. Now you'll know why delayed. It's not a direct damage. I'm having a mutation that damages my endothelium, as opposed to the second one which we saw, direct thermal heat, direct touch, direct damage. Here is an indirect damage. That's why I have delayed. That's why it's going to be delayed response. It will not be immediate. How delayed? It can be delayed for 12 hours or so. Prolonged. Because I have to repair the mutation, make sure the damaged endothelium comes back to normal, so it's going to be prolonged. I need time for this as well. Okay, that's why it's going to be prolonged. Again, prolonged for how many days? Again, for maximum 24 to 48 hours. So I'll have an inflammation which starts only after 12 hours. I'll have an inflammation continues for 1 to 2 days. What I'm going to relate this to sunbathing is, when you stay in the sun, you will not immediately turn tan. You will not immediately become dark. You will become dark only after 1 or 2 days, right? Because inflammation happens after 1 or 2 days. Tanning is nothing but subjecting your body to inflammation. That's all. That's all is tanning. Whenever there's inflammation to skin, it will turn black. You guys know it. I'm wearing specs. This part will be black because inflammation to my skin. The same thing happens here, but UV rays. It will stop, obviously, because otherwise the white guy will become a Negro, right? That will not happen. It will stop, obviously. It will come back to normalcy, fine? That's why I have delayed and a prolonged response. Sunbathing is not required for us. Useless thing. How am I going to relate this to practical medicine? Practicality is always the clue. How am I going to relate this to practical medicine? Is when you give an radiation therapy for cancers, this is very important because I am going to use the same radiation, not UV rays, some other different type of radiation to treat cancers. So when I treat cancers, what is most important is I am not going to look for the side effects the next second. I'm going to tell the guy, come after 2 days and see me again. Because you'll have the side effects after a couple of days, after 2 to 3 days. After 2 to 3 days only I'll have an effect. Immediately don't look, there'll not be. Because radiation causes delayed damage only. It'll never cause an immediate damage, right? And the second cycle of radiation, because radiation therapy will require cycles, give at least 10 days gap minimum. See, I'm not saying exactly 10 days, I'm just saying you have to have a gap. Second cycle should have minimum of 10 days gap because I need the damage tissue, everything to come back to normal, right? That's the reason I have a delayed and a prolonged response to radiation. It's extremely important for us because we are going to use this in day-to-day scenario in cancer radiotherapy, right? Perfect. Third thing we saw about endothelial gaps, right? Next, the fourth one is going to be leukocyte mediated permanent injury or permanent damage. This leukocyte mediated permanent damage. This is going to be seen in severe type of injury, very severe force. For example, burns. In burns, what's going to happen is I'll have a permanent damage. My entire capillary wall is being stripped off. First, I'll have a force. After that, my WBCs will come. My WBCs only will destroy all the vessels. That's why leukocyte mediated damage. It's permanent. I cannot replace them. I'll replace them only when a new blood vessel is being formed. New blood vessels takes at least 1 week to form completely. Till that time, I will have vascular leakage. That's the reason if you have read burns in your surgery, you are told that the first initial week of burns is the most difficult to manage because the patient will have hypovolemic shock. Entire body blood vessel is having increased vascular permeability. Hypovolemia and shock, first week. And first week is the most critical time in burns because to manage this as well as infections. Fine? So when you have a severe burns, what's going to happen is I'll have damage to endothelium, but it's going to be permanent. When there's a permanent damage, I'll definitely have a leakage, no doubt about it. There will be increase in vascular permeability. But the unfortunate thing is, this vascular permeability will stop only when a new blood vessel comes. This vascular permeability is going to stop, it stops after neoangiogenesis. Till that time, it's not going to stop. When it's not going to stop till that time, I'm going to have a leakage. Neoangiogenesis will easily take 5 to 7 days. So the first week is very, very critical for burns because an irreversible damage, completely gone, completely destroyed, right? That's about the fourth type of inflammation. Fourth type of vascular phase, right? I can have so many things. I'll add one more fifth also. This is for Baba Ramdev fans. See, sorry if you're a Baba Ramdev fan, I cannot help it. I don't like him, so I'm going to say it, fine? If you hurt your feelings, sorry, fine? So, when I have something called as transcytosis as well. So few people still believe that a WBC can just walk across my endothelium, which means there is a door here, I'm just going to walk across my door. Not so much proven. Some people still believe that if this is my endothelium, okay, my WBC can just walk like this. It can go like this. Without any damage only, it can go out. That's called transcytosis. And they also say that VEGF promotes it. The recent editions of Robbins have removed it, but just since I am going to the old one, I'm just including this as well. These are the 5 ways by which my endothelium or my vessel can help in the increase in vascular permeability. So vascular phase is done now. We're not gone into cellular phase. Cellular phase will take few minutes, that's all. So vascular phase is done. The next one is we are going to go is to cellular phase of inflammation. One thing I want to tell here, there's a huge confusion about endothelial contraction and endothelial retraction. That's been dropped. The entire concept of endothelial retraction has been dropped. So don't get your head into it and get yourselves confused. There's only one change in endothelium, which is contraction. Fine, that's all. Fine. So done. We are done with the vascular phase of inflammation. Next, we are going to go is to cellular phase of inflammation. Cellular phase is very simple, right? I'm just going to give you an explanation for cellular phase. If you are able to relate, that would be the best. Have you ever, if you are a guy, have you ever sneaked into a girl's hostel? If you have done that, you'll never forget cellular phase of inflammation. Guys, you have not done that, imagine this how it will look, right? So when you move into a girl's hostel, especially with a strict warden, you will never walk in the center of the corridor, right? You'll go and walk along the sides of the corridor so that no one will see, right? Like slowly you'll go and walk along the sides of the corridor. There'll be multiple doors there. You'll wait for one door to be open, which should be your girlfriend's room, right? You go there, you slowly crawl along the corridor, and if the door is open, you're going to stop there, look for anyone, and then go inside. That door opened is my vascular phase. You're going to go inside, and then you go in, the cells come outside, chemotaxis happen, and ends in phagocytosis. I'm leaving it to your imagination, right? So that's about cellular phase of inflammation. I'm going to compare it with selectin-dependent rolling, that is moving along the wall. Integrin-dependent adhesion, stopping at your girlfriend's door. Very important, you should stop only there. Otherwise, some serious problem, right? Adhesion. When the door is open, the door opening is my endothelial damage by vascular phase. If the door is open, if the door is not open, come back. Sorry, unfortunate thing. If the door is open, I'm going to go into the room. My cell is going to go outside my blood vessel, diapedesis. Then with the help of chemical signals, it's going to go to the site of inflammation, chemotaxis, and ends up with phagocytosis. You'll never forget. If you forget this, you're not done it. You should do it, right? Fine, you should breathe, that's what it means. And we'll go to the cellular phase of inflammation. So the first step, I'm just going to write the steps here. The first step is rolling. The second step is adhesion. The third step is diapedesis. Right? We have rolling, we have adhesion, and we have diapedesis. Fine? Those are three steps of cellular phase of inflammation. So first we'll look at it. I'll show you a video, I'll show you two videos. Once that is done, you'll have a basic concept of what is rolling and adhesion. Then we'll move to the theory part. Fine? This is the first video. You have your endothelium, and those tiny things which are on top of the endothelium are your selectin molecules, and your brave neutrophils comes inside. When neutrophils comes inside, those tiny yellow bloods are a Cialis-Lewis X receptor. It's going to bind to a selectin, but this binding is weak, so my blood pushes it, so it rolls. It's weak, my blood pushes it, so it keeps on rolling. It keeps on rolling till it finds the vascular phase. Till it's going to find the vascular phase, it keeps on rolling. Once it has found the vascular phase, what will happen is it will bind. The LFA, all those things are integrins, I'll tell them. And it's going to bind. Once it binds, it's permanent, it's adhesion. Then it's going to squeeze itself through my endothelium. Look, it squeezes into my endothelium, goes outside, and those green dots there are your chemical signals. Based on the green dots, it's going to move slowly to the site of action, which is where your bacteria is going to be, right? That's the entire cellular phase in two videos. It's simple. It's very simple. Very simple to understand. What we are going to see is, we are going to see what are the molecules involved here, right? The first step of rolling is what we are going to see first. We're going to have rolling. To understand rolling, we're going to have two molecules. One is the Cialis-Lewis X on the neutrophil, and other ones were the selectins, right? First we look at the selectins. The first one is selectins. Just for a factual based thing, selectin's other name is CD62. What is the other name for FAS? CD95. Good. Just recollect them. Selectins are CD62. We have three types of selectins, of which two are involved in inflammation. E-selectin, P-selectin. These are the two words involved in inflammation. And we have one more selectin, I am writing this, called as L-selectin. L-selectin is not involved in inflammation, so we'll keep it in the corner as of now. So E-selectin, as the name says, they are going to see in the endothelium. They are seen in the endothelium. See, I am just giving you the raw data, then we'll see how it happens in real life. P-selectin is seen on the platelet and endothelium. Fine, seen in platelet and endothelium. In endothelium, P-selectin are stored in a body called as Weibel palate bodies. Maybe asked in an MCQ. They are stored in a body called as Weibel palate bodies. In endothelium, they are stored like that. Okay. Along with one more factor called as von Willebrand factor. In endothelium, they are in Weibel palate bodies. We have P-selectin along with von Willebrand factor in that Weibel palate bodies. This is the normal location, right? This is the normal location. And we had Cialis-Lewis X receptor that was on a neutrophil. Our neutrophil will have, the WBC will have Cialis-Lewis X receptor. Okay? That's what we are going to have in the WBC. So we have two armies ready. Next thing is how they are going to join. That's the most important thing. Normally, in a normal state, when there is no inflammation, this E-selectin and P-selectin will be inside. They will not come outside. They will be inside dormant. So who is going to tell me, see there's an inflammation, come outside. So I need a stimulus for that, right? That stimulus is most important. So the first thing is going to be, I'm going to have an inflammation here. Some inflammation. We took the streptococcus as an example here. We'll have some inflammation here or injury. This injury, the microbes will release few inflammatory cytokines. I'll have cytokines from the injury or from the microbes. We'll have TNF, tumor necrosis factor, one of the important one. And we'll have chemokines. We'll read what are chemokines soon. These chemokines and tumor necrosis factor, what they're going to do is they're going to expose or increase E-selectin. They'll increase the E-selectin expression in the endothelium. Fine. That's for E-selectin. Then what's going to help P-selectin? For P-selectin, I'm going to have histamine. That also is an inflammatory mediator. We'll read all the inflammatory mediator in next few modules. And we have thrombin. This too is going to redistribute P-selectin. See, because P-selectin is stored in a Weibel palate body, I have to just take from the Weibel palate body and put it up. E-selectin I have to synthesize, right? We'll redistribute P-selectin. Right? This is very important. So what happens is, I'll just write a draw a normal endothelium here. This is my normal endothelium. It has no E-selectin, and I'll put it like, these are my Weibel palate bodies. Different color. The P-selectin is inside. Right? I'm just writing here, these are Weibel palate bodies. I'm writing WP for Weibel palate. This is normal, non-inflamed endothelium. When inflammation happens, when all the cytokines comes, when the thrombin comes, when the histamine comes, they're going to change totally. What will happen is, same thing only, same endothelium. My E-selectin comes on the top, and the P-selectin gets redistributed. That also will come on the top. Fine? That also will come on the top after inflammation. Before inflammation, nothing happens. That's the reason I will not have a binding or rolling before inflammation. Only happens after inflammation. Once this happens, we saw the video, right? Once this happens, it's perfect. I have E-selectin and I have P-selectin, and my WBC here will bind to it. With help of Cialis-Lewis X receptor. right? It will bind, and this bond is weak. This bond is a weak bond. Since the bond is weak bond, the blood flow will push it, will detach it. So it goes and gets attached once again. Blood flow again detach it, gets attached once again, and it'll keep on rolling like that. That's how rolling happens. During this process also, I'll have one more molecule in my WBC called as integrins. They'll be in inactivated state again. So this process of rolling goes on till the WBC meets the vascular phase. That's why I said both happen simultaneously. When I meet the vascular phase, I know that I have an opening here, I have to get out. Otherwise, I'll be gone. Right? So when it meets the vascular phase, I'm going to go to the next step, which is adhesion. As a second step, I'm going to go to the next step, adhesion, when it meets the vascular phase. Right? At the site of endothelial response. That's what I'm saying it as vascular phase. Fine? So this also happens the same way. I'll give the data first, what are integrins, what are the ligands, and then we'll see how it changes from inactive state to an active state, right? So I have two things here. One is integrins. So integrins are seen in WBCs, the neutrophils. The other molecule is going to be called as CAMs. CAM is cell adhesion molecule. See, this is seen on the endothelial surface. So I have integrins and I have CAMs. We have two groups of integrins, beta 1 integrin and beta 2 integrin. And we have two CAMs, I CAM and V CAM, right? We are going to see what binds to what, that's all. We have two groups of integrins, beta 1 integrin. I wanted to know this because this based on the beta 1, beta 2 only, I have few diseases. And I have beta 2 integrin. Fine, I have two of them. So beta 1 integrin is my VLA4 and alpha beta 47. That's beta 1 integrin. And beta 2 integrin is my LFA1 and MAC1. Right? So this beta 1 integrin binds to my VCAM. CAM you already know. V stands for vascular. Vascular cell adhesion molecule. LFA1 and MAC1 binds to my ICAM. CAM you already know. This stands for intercellular. That's how it binds. But as I said that initially integrin will be an inactive form. Who makes it active is TNF chemokines. Of the chemokine, interleukin 8 is very important here. So this will be in inactive form generally, but as a result of inflammation, I'm going to have increase in amount of cytokines and chemokines. When I have that, especially interleukin 8, when this guys happen, this is going to convert an inactive integrin or in an inactivated form to an active integrin. When it becomes active integrin, it binds with my cell adhesion molecules. It's going to bind with my cell adhesion molecules, and this binding is very, 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 very strong. No amount of force can detach it, so it's going to get adhered. It's going to get adhered. It's very simple, right? We're just giving few information. See, information remembering is a bit difficult, but don't worry. We'll read again and again, and we'll remember whatever we need to know. That's more than enough for us, right? So beta 1, beta 2 integrin, and we have CAMs. It will bind. The binding is totally based on inflammation. That's why in normal condition they don't bind. So next step is done. So I'm close to my door which has been opened. I'm just standing there and waiting for it to go inside. For that also I need persons here. I need molecules here. The next step is called as diapedesis. Okay, it's diapedesis. So diapedesis is nothing but crossing my endothelium is diapedesis. I'm going to go outside. Or in other words, I'm going to call this transmigration through the endothelial wall, through endothelium to extravascular space. That's the classical definition of diapedesis. Right? To extravascular space is diapedesis. Fine. Clear? So for diaperesis, I need one molecule, PECAM. The molecule which I require for diabetes is PECAM. PCAM. The other name for PCAM, just CD marker, CD31. I'm just recollecting again. CD62 is selectin, CD95 is FAS, and CD31 is PCAM. So when they are there, so what will happen here is, I'll tell you exactly what happens. I'm just going to go a little bit in detail. We are going to just zoom out what is there in my endothelium. So this is my endothelium, the cell, and this is where the endothelium has undergone damage. So I'm not drawing any endothelium there. But I also have one more guy, basement membrane. Right? I have the endothelium here. I'm just putting an arrow mark to say the site of damage. Plus I also have basement membrane. What is basement membrane made of? Collagen. Right? Type 4 collagen to be specific. So my neutrophil, with the help of integrin, has stopped here. It has stopped there. Adhered there. With the help of PCAM, let's use yellow color. With the help of PCAM, it can move through the endothelium, right? It can move through this. I have one more person waiting there for me to block. Now what my neutrophil is going to do is secrete some collagenases. The granules of neutrophil have that. Right? Now what they're going to do is, we are going to have collagenase. When collagenase happens, it's going to dissolve a little bit of my basement membrane here, so that my neutrophil can easily come outside. Right? This entire process is going to be called as diaperesis. It can easily squeeze through and it's going to come outside. Right? Both are important. My PCAM is also important. My collagenase is also important for me to come outside. Now I'm free. I'm feeling very happy. I've come outside. I need to go to the site of inflammation. That's my next role. I need to go to the site of inflammation, right? I need to go to the site of inflammation. So next step is going to move towards the inflammation site. To move towards the inflammation site, okay, using chemical signals. That's why I'm going to call it chemo. Since I'm using chemical signals, taxis is movement, taxi. Right? Chemotaxis is movement. That's my next step. Fine. So what helps me for chemotaxis? There are lots of chemical mediators which are going to help me for chemotaxis. What you're going to see under chemotaxis, what helps me, and how exactly chemotaxis happens. That also is required for me, right? How exactly a chemotaxis happens. So what's going to happen is, first we'll read what are the chemotactic signals we need to know. So for the signals of chemotaxis, we're going to divide for our comfort as exogenous signals and endogenous signals. See, exogenous is little, endogenous is plenty. Exogenous means bacteria. Bacteria will give me a signal that, see, I have come inside, lipopolysaccharide, find me and come and destroy me. Right? These are bacterial products. The bacterial products give me signals so that I can find the villi proteins, the flagella proteins, the lipopolysaccharide of the cell wall, everything. I'm just giving an example of LPS, lipopolysaccharide of the bacterial cell wall. That will give me signal that I'm here, come and find me and eat me. One, that is exogenous. Endogenous are plenty. See, endogenous signals, one of the important signals is complement proteins. Of complement proteins, we have C5a. The C5a complement protein is one of the most important thing here. Okay. We have interleukin 8. We have leukotrienes. We have leukotrienes. Okay. Fine. We have all these. These are my chemotactic factors. And the most important entire group called as chemokines. We'll also read about chemokines now. This is one of the biggest group which is going to help me for chemotaxis. As the name says, chemokines. Apart from that, they also do help me. So what are chemokines? These are molecules synthesized at the site of inflammation which is going to help me for chemotaxis. There are different molecules which are going to attract different groups of cells, like neutrophils molecule, lymphocytes 1, eosinophil 1, different chemicals for different inflammatory cells, right? That's what we're going to see. So what are chemokines? Chemokines are they are very, very tiny proteins, 8 to 10 kilodalton, it's capital D, kilodalton proteins, the molecular weight, which are going to help me in the chemical process. We have totally 4 groups of chemokines. The first group of chemokine, I'm going to call it CXC chemokines, right? The name is based on cysteine residues, and X is the amino acid. The number of amino acid between 2 cysteine residues is where I'm going to divide them into. That's not much required for us. We'll see what are the chemokines and what is going to attract. That's more important for us, right? CXC chemokine. This CXC chemokine is secreted by macrophage. Macrophage is the site of inflammation. It's secreted by endothelial cell at the site of inflammation. The guy here, the most important guy is interleukin 8. And this is going to attract, I'm just saying, attract which group of cells here? It's going to attract neutrophils. Fine, it's very, very important for neutrophils. They actually secreted at the site of inflammation. It's going to attract my neutrophils, right? Next. The second group of chemokine is called as CC chemokine, which means there is no amino acid between the cysteine residues. That's what it means. X is for the amino acid, right? So CC chemokines, what I have here is, we have plenty of chemokines here. I'm just going to write the chemokine name and the cells which are going to attract, right? We have something called as MCP1. Okay. We have something called as macrophage inflammatory protein 1 alpha, MIP1 alpha, and we have eotaxin. The first two, monocyte chemoattractant protein MC1 and macrophage inflammatory protein MIF alpha, protein 1 alpha. These guys are going to attract, those are the chemical products in this group of chemokines. They're going to attract, as the name says, lymphocytes and monocytes. This eotaxin is going to attract eosinophils. So I have two subdivisions of chemokines under this group, CC chemokines. One is going to attract my mononuclear cell population and one is going to attract my eosinophils, right? That's my second group of chemokine. This can be asked as an MCQ point. See, if I want to create an clinical scenario here, I will give you an parasitic inflammation or infection and I'll ask you which chemokine is going to help me to get the WBC in order to kill the parasite. So I'm talking about eosinophil. So you can create a clinical scenario also with this base, right? The third group of thing, it's called as C chemokines. Just C. Chemokine. Fine. The third group is called as C chemokine. Here I have something called as two molecules. We have lymphotactin. As the name says, you know that it's going to help me to attract lymphocytes, and also XCL1. If you remember lymphotactin more than enough, it's going to attract lymphocytes. That's for lymphocytes. Fine. The fourth, last but not the least, we have CX3C chemokine, which means I'm going to have 3 amino acids between 2 cysteine residues. CX3 chemokine, there's one important thing which has been asked as an MCQ previously called as fructalkane. This CX3 chemokine group has fructalkane. So what Robin says is this fructalkane has 2 components, and membrane bound component, okay, and also an soluble or a secretory component. Fine. So both are going to help me in to deal with one group of cells only, but the membrane bound component is going to help in the increase in adhesion or like an activation of that cell, and the soluble component is going to help in the chemotaxis of the cell, that is movement of the cell. Which cell? It is mononuclear T cells. Okay, mononuclear T lymphocytes is the one which I'm going to target. This fructalkane is going to bring me mononuclear T cells, both for addition as well as for my chemotaxis, for my movement as well. It's going to help. So these are the chemical mediators with the help of which my cells can move to the site of inflammation. I know the chemical mediators. Next, how do I move? For in order to move, I need only one. My entire body, there's only one protein which helps me move. Muscle, actin, right? Same thing happens here. How do they move us? At the leading edge, you'll have actin polymerization. There'll be actin polymerization, which is going to happen in the leading edge of neutrophil. It happens in the neutrophil, which helps in movement. That's all, right? So I'm going to have actin polymerization. I'm going to kind of send a pseudopod, keep on moving like an amoeba to the site of inflammation. Once I reach the site of inflammation, I am going to destroy my cell. That's the biggest challenge here. I'm going to destroy my cell. I'm not going to leave any evidence of destruction. Who do I need? The cells which are going to function as macrophages. Every WBC in macrophage. Every WBC can eat, but macrophage can eat many things. Neutrophil also can eat, right? Little bit of it. So the last one is going to be phagocytosis. Fine. The last one is going to be phagocytosis. I'm going to eat it and I'm going to destroy it inside me. Okay? That's what we're going to see here. So in phagocytosis, I'm going to concentrate on the majority or major part of destruction. I can destroy in many ways. Once I engulf the bacteria, I can destroy in many ways. The most important for me is oxygen-dependent destruction or respiratory burst. That's what we are going to concentrate more. The other one, I'm not going to concentrate much about, but I'll tell about that as well. Fine. So for phagocytosis to happen, I need recognition. I need to recognize that there's a molecule here. Once I recognize it, next I'm going to just go and engulf it, and next I'm going to destroy it. I need all the three steps, right? The first step in phagocytosis is recognition. How I'm going to recognize that there is a bacteria there. That's my first and the most important role. For recognition, I have few receptors. The first one is called as an mannose binding receptor. This receptor binds especially to the glycolipids in the bacterial wall. Human cell wall doesn't have that, so it's only selective for bacterial cell wall, right? The mannose binding lectin is selective for bacterial products only. So that I will not eat a human cell, I will not eat anything related to human, I will eat anything related to bacteria only. Second called as scavenger receptor. This also helps me. Third is the most important thing. You must have heard this for sure. Whenever I have a bacteria, I'm going to coat this bacteria with something tasty, opsonization, right? So the opsonins is going to help me to recognize, because phagocyte will have receptors for opsonins, right? So what will happen is the bacteria will be coated by the most important opsonin for me is C3b. I'll have C3b and also I'll have IgG. So this macrophage is going to have receptors for this. You'll have receptors for this opsonin. That also will help me engulfing. Right? You'll have receptors for opsonins. That also will help me engulfing. So I've engulfed it now. I've eaten it now. So how do I destroy? So once I've eaten it with the help of all these receptors, three of them, mannose binding lectin, scavenger receptor, and receptors for opsonins. Once I have done that, I have to destroy. I have two ways of destruction. One is with the help of neutrophil granules. There are plenty of neutrophil granules. You cannot remember it. We'll read it whenever we require. In different stages of pathology, we'll identify the use of one or the other granule. In that way, we'll compile it at the end. Initially, it's very difficult to memorize everything. One is neutrophil granule mediated destruction. Non-oxygen required. And the most important thing, what we are going to read is respiratory burst. Right? We are going to read about respiratory burst. That's my most important thing. That's what we are going to deal about now. Oxygen dependent killing of the organisms. Very important and very, very interesting. Like any other pathogenesis we learned here, We're going to read about normal, then we're going to read about abnormal. Okay, ready? It's quite a big module, right? Smile, smile. You should not lose the enthusiasm. Enthusiasm is going to be there till the end of your life, right? Smile, maybe have a cup of water and start back. Never ever stop it, right? Let's start. Let's start about respiratory burst. We're just going to read about this. In order to know this, I need few basic concepts so that I can understand it. Fine? So we all know that when I eat an organism, I am going to put like a phagosome. This phagosome will bind to my lysosomal molecules, the lysosome. This lysosome will have enzymes which will help me in the destruction. That's all. So what do I need to know is, what does this lysosome have which will help me in the destruction? So that's the first thing we're going to see. In order to understand respiratory burst, you're going to see how will a lysosome look and what are the things which are required in the lysosome so that it can destroy with the help of which can destroy my microorganisms, right? This is a normal lysosome which is not fused into a phagosome, right? A normal lysosome, what will have is a normal lysosome. I'm just putting around. I'll have two components or subunits of the same enzyme here. See, one is in the membrane. I just put close to the membrane. Other one is in the cytoplasm of the lysosome, right? This membrane bound component, I have a membrane bound component and I have a cytosolic component. I have a membrane bound component and I have a cytosolic component of the same enzyme. The green color guy is NADPH oxidase. As the same enzyme, two components in a normal lysosome. So why do I divide it and keep? So that they are inactive. Like your biochemistry PDH complex, there are 7 different enzymes, right? All are inactive. When all comes together only, they'll become active. I have kept it separate so that my normal lysosome is not digest. I've kept it separate and they are inactive. They'll become active only when they bind with each other. And when will the binding happen? When phagosome and lysosome fuses. Clear? This is normal. I want you to know it. I want you to know there are two components, because when either of the component becomes abnormal, I'm going to have a disease which we'll be seeing in next module. Clear? So this is normal lysosome. And this, I'm writing it here, it is inactive. It's inactive because both are separate. Now let's come to a macrophage. And the macrophage is phagocytose the bacteria with the help of my receptors and opsonins. I have a macrophage. Okay, I'll remove the circle, right? So let's have a macrophage. And this macrophage is which is engulfing my bacteria. I'll put in green color for the bacteria. Oh, the NADPH is also green, right? We'll put a red color. It's engulfing the bacteria. Once it engulfs the bacteria, it's going to form an entire vesicle kind of thing, which will have the bacteria inside them. And for understanding, I also have the lysosome here with my green NADPH oxidase. I'm just putting it again separately, right? So this guy is called as a phagosome. This guy is my lysosome, right? So the next step here is phagolysosome formation. See, this is the most important thing. I need to form phagolysosome. Once the phagosome and lysosome fuses, we just put like this, it's going to fuse. See, I've removed the macrophage wall. I'm just having the phagosome and lysosome. My red color bacteria is here. When it fuses, these both NADPH oxidase also fuses. Most important. Initially, it was separate. When phagolysosome fuses, both the component fuses. When this fuses, when the membrane and cytoplasmic component fuses, the NADPH oxidase will become active. The NADPH oxidase becomes active. That's my most important thing. This NADPH oxidase is going to help in my destruction of my bacteria. We are going to see how. I called it respiratory burst because it's going to use oxygen. It's an oxidase. Obviously, it loses oxygen, right? So what they're going to do is, it'll take oxygen. We're just going to write the chemical reactions now. We're coming to the fag end of the story. Little bit more patience, right? When you have oxidase, oxygen, I'm going to have NADPH oxidase. As the name says, it's going to oxidize it. So it's going to make it superoxide. Fine. Whenever there is superoxide, which enzyme will come? Perfect. SOD. Superoxide dismutase. Superoxide dismutase reduces my superoxide into hydrogen peroxide. Very good. This hydrogen peroxide is also a free radical. See, this hydrogen peroxide is going to have two fates depending on the cell where it is produced. I'm going to consider two cells, neutrophils and eosinophils, right? Depending on the cell where it's being produced, it's going to have two fates. If it is neutrophil, I'm going to have an enzyme called as MPO. See, this is one of the granule contents, myeloperoxidase. MPO is myeloperoxidase. As the name says, hydrogen peroxide is a peroxidase. This myeloperoxidase, with the help of that, it will combine with chloride ion, hydrogen peroxide. With the help of myeloperoxidase, it will combine with chloride ion and I will form HOCl minus, hypochlorite anion. Did you hear this somewhere in the first chapter? Yes, we did. Most effective bactericidal. This is the most effective bactericidal free radical. It will kill the bacteria like anything. And I'm sure that your mom knows it better than you. How? Dettol, Lysol, all of them are hypochlorous acid. All of them are hypochlorous acid. They kill bacteria. You have seen advertisement, right? 99.9% destruction thanks to hypochlorous acid. Your body uses it, right? And that will be seen in neutrophil. So I'll give you one more revealing point here. It will be amazing. We are going to just understanding a body, that's all. In pathology, we are just going to understand our body. If it is one more protein, I'm writing this called as MBP, the second arm. MBP stands for major basic protein. If it's MBP, it's going to combine with iodine and it's going to form hypoiodide, right? I think it's HOI. Hypoiodide. If my formula is wrong, ignore it. It's going to form hypoiodide anion. This is going to destroys the parasites. It's going to destroy the parasites. And this major basic protein is seen maximum in eosinophils. See, now the plate changes. So what we have read till now is, when I have parasitic infection, I have eosinophilia. That's what you have been reading from, even sometimes from your 12th standard. Parasites, eosinophilia. It's actually the reverse. My body knows that, say I'm having a parasitic infection, I need hypoiodide to kill my parasite. When I need hypoiodide, I need major basic protein, so bring in eosinophils. That is your body's decision. He is the mastermind behind everything. So only when eosinophil comes, I can produce hypoiodide and I can effectively remove the parasite. That's actually the reverse. Parasite stimulates eosinophilia. Eosinophil comes and destroys the parasite. Infection and inflammation. Bacteria needs MPO because it needs HOCl. So for all bacterial infection, I'll have neutrophilia. Right? My body knows what I have to use to destroy them. So once this comes, my destruction is perfect, without an evidence, without a clue. So my ultimate aim is done. We are happy now. Right from the start, the neutrophil took long time to come here and destroy everything. Now I have one more job left. Very small job, but most important job. I have destroyed my streptococci. I have to tell to my blood vessel, guys, stop. Don't send me more neutrophils. Enough. Because I have done the job. If you send more neutrophils, I'll have more damage. I don't want that. I have to stop the inflammation. Termination of inflammation. I'm just going to say 2 or 3 words, that's all. I need to terminate inflammation. When you start something, you have to finish. Learn from your neutrophils. When you start something, you have to finish. When you start a video, you have to finish. Don't stop in between. Learn from your tiniest organisms, organs or cells which are going to protect you. Start should have a finish. Termination of inflammation is very important. Otherwise, I'll have uncontrolled inflammation causing damage. For termination of inflammation, we have few mediators: lipoxins, interleukin 10, and TGF beta. These are three main molecules mentioned in Robbins which are required to terminate inflammation. This is going to tell me my endothelium, stop your vascular permeability. I am done. Don't send me more cells. That's what is the goal of this, and that ends this chapter. I'm putting a star here. That will be helpful for the next process after inflammation, which is healing. That we'll see in the healing chapter, right? Okay. Exhausted, right? Even I am. Okay, let's go back. 2 minutes. We'll just revise everything. Close your eyes. Close your eyes. Just 2 minutes. We'll go brush through everything, whatever you read in this module. Then we'll call it a day for this module, right? Close your eyes. I'm also going to close my eyes. We started about acute inflammation, the process of acute inflammation. We divided them into vascular phase and cellular phase. When there's an infection or inflammation, transient vasoconstriction, then vasodilatation happens, turbulence happens, margination happens. And we saw 5 methods of endothelial being giving way. Coffee spill, cooking related burn, remember your mom, sunbathing, remember Goa, leukocyte mediated injury, burns, and one transcytosis, which is okay. So with these things, I'm going to have cellular phase happening simultaneously. Selectins and your CLL-Lewis X receptor helps in rolling. Integrins and CAMs helps in addition. PCAM helps in release with the help of collagenase. And we saw a whole lot of chemokines, 4 groups. We saw interleukin 8, endogenous and exogenous chemoattractant, comes to the site of infection. Phagocytosis happens with the help of receptors and opsonins, and then oxygen-mediated killing called as respiratory burst. We had NADPH oxidase in 2 forms inactive. When phagolysosome fuses, they become active, and then we had 2 pathways: production of O2 minus, H2O2 with the help of MPO formed HOCl, with the help of major basic protein formed hypoiodide, kill bacteria as well as eosinophil, and then we terminated inflammation with few of them. Right? That's all. That's all is the entire thing over inflammation. And yes, let's continue. In the next video, right, swipe right, at least here, right? Let's continue the next video and we'll see about the disorders of inflammation, which is more interesting. I want you to understand this completely. Then disorders of inflammation becomes very simple and very logical, right? Till then, keep smiling. Have maybe 2 cups of coffee this time because of a big module. And come back. Till then, bye-bye from Dr. Halim. Bye-bye.